what I'm trying to do is make you a little more comfortable with managing acute COVID in the ambulatory setting. What we're not going to be talking about today is the inpatient management of COVID, which was nicely covered by Dr. Hardin on Monday. And we're not going to be talking about vaccine-related side effects, sequencing of vaccines, and other vaccination questions and variant questions as well. We're going to be focusing on a symptomatic patient who comes to you, who you either suspect or know is infected with SARS-CoV-2. So we got started in mid-March of 2020 when the pandemic was just making its way here to Boston. We were not hit nearly as hard as New York City or Northern Italy, but we had many, many cases at the same time in between late March and April, to the point that all medical care shut down except for COVID care. At that time, we set up an ambulatory practice. Cambridge Health Alliance set up this practice where we just saw patients who had COVID or other respiratory diseases. And that's where we had our experience, where we were caring for thousands of patients in that setting. And I'll be speaking from based on literature, but also on our clinical experience in our COVID clinic. Now, here's an outline of what we're going to try to get through, and it's a lot of material, so we'll see how far we get in the next 50 minutes. First, we're going to review the natural history of COVID, which is incredibly important. Pay attention to the time course, because that's going to hugely affect care. Here's a little video I recorded on the natural history. COVID starts with a wide variety of symptoms. It's quite challenging and actually impossible to distinguish these symptoms from a multitude of other viral illnesses. So the initial symptoms that someone might have might be a sore throat, fever, a cough. GI symptoms, maybe abdominal pain or diarrhea. Other patients develop vomiting. But sometimes COVID can be entirely asymptomatic. So it really runs the gamut from asymptomatic to a very strong virus, like influenza. It may look like strep throat, it might look like a bronchitis, or even a GI bug, or even having eaten something a little off the night before. At this stage in the illness, it's basically impossible to distinguish a patient with COVID from a myriad of other common ailments. And if this is all that we knew about the presentation, we'd pretty much be at loss, have to throw up our hands and say, if you have pretty much almost any symptom, including headache, you might have COVID. But there are some tips, some hints that something else is going differently. One of the things is that very early on, people might lose their sense of smell. This could very well be a tip-off that we're dealing with COVID. But what happens next gives us some hints to the diagnosis. What's most important about all of these early symptoms, including rash, is that we haven't yet seen dyspnea. Shortness of breath, interestingly, does not seem to be a common initial presentation for COVID. What happens is that after this initial viral-like illness, time passes. These symptoms may continue, they may even improve. Somewhere, maybe between days 4 and 8, there's the development of dyspnea. Now, when dyspnea develops, sometime between days 4 and 8, are the most critical days of the illness, and to carefully assess our patients to make sure that they're not worsening. Because a subset of people who develop dyspnea will do relatively poorly, potentially developing ARDS, and require intubation. We also know that there are many patients, and hopefully it'll turn out to be the majority of patients, who develop dyspnea, who will have a stable clinical course and will not require intubation, might not require even hospitalization. So with that overview, which is probably familiar to most of you, let's dive into our first case. So here I'm going to ask you to choose an answer and to what you would do in this situation. Here we have a 51-year-old unvaccinated male who's originally from Brazil, living in the States. He has no significant past medical history, and he's on day 2 of illness. He describes to you that he has nasal congestion and mild cough for the last 2 days, but no other symptoms. He works in construction, and a coworker of his, whom he was working very closely with, tested positive for SARS-CoV-2. And you'll see the options here. They involve how to, what tests to perform, whether or not antibody or antigen or PCR. They involve whether or not he needs an inpatient evaluation. Should he be seen in person? Should it be by televisit? And at what point? Or if there's no follow-up necessary. So please respond to something, and then you can see where others have landed on this. Okay, great. So the overwhelming majority of you would recommend arrange for same-day drive-through testing without any in-person or televisit follow-up. So let's see how to approach this question. My recommendation is to think about first, what is the best, when you have someone who likely has COVID, what's the best setting for their evaluation? And there's really 4 key items to consider whether or not to see someone in person. We want to know how high risk the person is for severe disease, figure out what stage of their disease is, and that's related to the video you just watched. Are they in that tenuous 4 to 8 day stage, or are they in an earlier or later stage? How severe their symptoms are, and then if any diagnostic testing is necessary. So we'll discuss all of these. As is well known by now, we have now worked out many risk factors for severe disease, which is the older you get, that is the greatest risk, but also male age, cardiovascular disease, diabetes, obesity, and many other conditions increase the risk of severe disease. But it's not just these sort of traditional medical conditions in age and sex that affect risk. What we've learned, or really had to relearn with COVID, is that it's social determinants of health are as powerful, if not more so, than those traditional risk factors. So it might be the conditions under which our patients are living. How are you living? Who are you living with? How closely do you live together? What's your work environment like, and how much of an opportunity do you have to protect yourself from other people in the work environment who might have COVID? These are questions that we have now become routine for all of us to be asking our patients, and also recommending screening for things like food insecurity, which can get particularly challenging in the setting of the pandemic, where some people, or maybe the entire family, is unable to get out or be able to work. These are just as important, in my opinion, to evaluate when assessing risk as are the traditional risk factors. Now, in terms of our patient, he's in the early stage of disease, being on day 2. His symptoms are mild, and he's born in Brazil, so that probably provides a little bit of risk, but that's the only potential risk factor that he has. So the next question is, what's the best test, diagnostic test, to detect SARS-CoV-2? So to understand this, it's best to turn back to this classic graph in JAMA that was published early on in the pandemic. Is really held up nicely. And what we see here is that there's 3 basic patterns. One is, well, let me talk to you first about the antigen presence. So this is related to the rapid antigen test. These are the types of tests that sometimes we have in medical settings, but are also available widely at pharmacies now, when they are available. And what we see here is that the antigen, this is the first day of symptoms here, this dotted line. And what we see is that the antigen becomes positive very rapidly, right at the start of symptoms, but then tapers off very, very fast in just a few days. And even at its height, it's not always detected. So there's going to be a number of cases that patients will have SARS-CoV-2, but the antigen rapid test will not be positive. PCR, and I'll use PCR today as referring to one specific example of NAT, or nucleic acid amplification test. That's a large category now of testing. And I'll refer to the reverse transcriptase PCR as this broad category of NAT testing. The PCR becomes positive rapidly when patients are symptomatic. It's more sensitive than it'll pick up more cases than the antigen test, but it has a much longer taper, so it's positive for a few weeks after the test, and even a few patients will remain PCR positive weeks and weeks after their initial infection. Now, the last thing I'd like to point out here is the antibody. So what you'll see is these dotted lines are antibody elevations, and what we'll see is that the antibody rises after the antigen decreases, and there's heterogeneity in the studies about how long antibodies stay positive after a natural infection. Some studies suggest for quite some time, and others that only a smaller percentage of patients remain positive. Of course, this is even less useful in the setting of vaccination, because vaccination will often cause the antibodies to increase. So the overview is that the PCR is more precise, more sensitive, and specific. But the antigen test, and we'll get into this later, has an important role in the management of acute COVID these days due to its ability to detect early infection and the turnaround time, which is much faster, sometimes only 15 minutes, compared to a day to 4 to 5 days for PCR testing. And the route of testing goes, I've listed here from the highest sensitivity is nasopharyngeal, so that's that deep nose test, nasal, saliva, and then pharyngeal has low sensitivity, so it's not recommended for testing. So let's talk a little more about the antigen test. As I mentioned, we have the results very rapidly. And there's two settings where antigen tests can be particularly useful. One setting is if you need to do broad screening rapidly before an event. You could take asymptomatic people and screen them, and it will help you identify a few cases of SARS-CoV-2, if there are any. Similarly, if someone has symptoms and they do a rapid antigen test, a positive test is confirmation that this is COVID. The key to remember is because the sensitivity is not very high for antigen testing, even if you have symptoms and you use the antigen test, if you have risks for that being COVID, then that should be followed with a PCR test, because you're going to miss a number of cases because of the low sensitivity of antigen testing. Now, one thing that is really important to think about is that the FDA has approved rapid antigen testing during the first 5 to 12 days of illness. I think this is a mistake, because really when antigen testing, as we saw in the earlier figure, is most helpful only in the first few days, the first 2 to 3 days of illness. So I really recommend that only using antigen testing early in the course of illness. In terms of antibody testing, there are many different antibody tests, so testing characteristics are not standardized. This makes it challenging. There are cases of other more common coronaviruses co-reacting and causing a positive test for COVID with the antibodies, and now with the vaccination, antibody test is even less useful than ever. So I rarely use antibody testing in my clinical practice. Now, one question that comes up not infrequently has been if a patient has a positive PCR test, should that be repeated? Sometimes employers ask for that, or schools. And the answer is it should not be. Once a PCR test is positive, the patient will no longer be infectious within, unless they're severely immunocompromised, within 10 days. So it's not necessary, and actually can be confusing, to check a repeat PCR test. So unless someone has a discrete new infection weeks after the initial COVID infection. I do not recommend repeating PCR tests. So back to our patient, I agree with the majority of you, which I would arrange for same-day PCR testing for this patient. And if one thing though to keep in mind, because I want one of the take-home messages is when to think about monoclonal antibodies, and we'll be talking about that shortly, is that if this patient was very high risk, let's say in their past medical history they had multiple medical problems and they were older, then I would recommend a rapid antigen test of this patient as well as a PCR test. That way the rapid antigen test could come back and then the discussion around monoclonals could occur. So now there's a lot of buzz on social media and the internet and among friends and family about a variety of different remedies, things that are used to treat or prevent COVID in the outpatient setting. So I wanted to just briefly touch on some of these areas because you're probably getting questions about them. So one question is whether or not NSAIDs are safe to use for symptoms. And initially, because of the mechanism, the anti-inflammatory effect, the concern was that it could potentially worsen later disease if we used anti-inflammatories early on in the illness. But fortunately, what's panned out in large cohort studies is that there's no increased risk of severe COVID from patients who used NSAIDs over acetaminophen. So we believe it's entirely safe to use NSAIDs to treat the symptoms of COVID, although we do recommend for safety, for general side effect profile being better, acetaminophen for symptoms in general. A lot of questions about vitamins. Vitamin D is one of the most talked about vitamins when it comes to COVID, or really when it comes to any disease. And so what do we know about that? Well, basically, what we know is based on many small studies. And we can find studies to support that it prevents, very small studies, 70 patients in Spain, appears to prevent, giving a vitamin D analog appears to prevent ICU admission to hospitalized patients. But larger, more high quality studies have not demonstrated the benefit of vitamin D for the treatment of COVID. And a very large cohort study out of the UK, which included over 300,000 patients, did not find surprisingly did not find an association between low vitamin D levels and severity of COVID. That's actually surprising to me, not because I think that I would have expected vitamin D to have that kind of powerful effect, but rather that vitamin D tracks with so many co-founders like obesity, that I might have expected that patients who are obese were more likely to have low vitamin D and more serious COVID. But once you controlled for those factors, there was no association, there was no increased risk, there was not association that suggested that low vitamin D levels led to more severe cases of COVID. What about colchicine? Now, colchicine, let me just say about vitamin D is that I don't recommend it. If patients want to take 600 to 1,000 international units, that's fine, of course, and that's what I'd recommend. I wouldn't recommend anything beyond that in my patients who are trying to prevent COVID or are sick with COVID. Colchicine. This is a much more interesting, actually, sort of clinical dilemma right now, because there is one study that suggests that one large study, including roughly 4,000 participants, that patients were randomized to colchicine or to placebo, and the finding was that it decreased severity of disease. So that leaves us with this question of what do we do about the situation where we have one large study to suggest something. And this is hotly discussed at UptoDate, and we've decided not to embrace this as standard of care. We would like to see another study. The study that showed decreased severity of illness did not show a mortality benefit, so we're comfortable waiting on this and not recommending colchicine as standard of care, especially because of the many side effects, as we know from using colchicine in gout and other conditions in the past. But what I would say, this is an area of much interest, and if I had a patient who was adamant, I need to take colchicine to treat this, that would be something that would be reasonable to try if a patient was really keen on it. Fluvoxamine, the antidepressant, actually, there's a small study published in JAMA which suggested some benefit, but that hasn't been replicated to my knowledge, so it's also not ready for prime time. Now, maybe the most controversial of all is ivermectin. Ivermectin, the amount of buzz and hype is just crazy, but when you actually take a hard look at the data, it's just simply not there. There's one very well done small study, also published in JAMA, showing no benefit in outpatient COVID. And other than that, we're really left on preliminary summaries of studies, but most of the meta-analysis suggests that there's not a benefit, so we definitely don't embrace the use of ivermectin antidepressant and recommend not using it. Antibiotics, including azithromycin, have been demonstrated. Azithromycin has been demonstrated not to be helpful, and what we're not seeing this pandemic, unlike the 1918 flu pandemic, was that we're not seeing a serious problem of secondary bacterial infections. That can occur, but it's not very common with COVID. So thinking we need to cover with antibiotics when we see someone with chest x-ray changes that suggest the atypical pneumonia in the setting of COVID is not necessary. And we can really avoid a lot of unnecessary antibiotic use by not prescribing antibiotics for patients who have COVID with atypical findings on chest x-ray that suggest an atypical organism. And what about inhaled corticosteroids? This is a very active area of being explored. There's been 2 well-performed studies looking at budesonide, and which is particularly a potent version of inhaled corticosteroids. And what they found in one study, there appeared to be a decrease in hospitalizations, but then a larger study did not pan out. It wasn't confirmed. In the larger study, there was self-reported decrease in symptoms, but it was only self-reported, and there was no change in hospitalizations or mortality. So budesonide, in my opinion, is not ready for prime time. And another area of very active investigation is, should patients, let's say with multiple risk factors and active COVID, receive anticoagulation in the outpatient setting. And as of today, I'm not aware of any study to suggest that's beneficial, but it's being actively studied, so that advice might change in the near future. So next, I just want to briefly touch on quarantining during acute illness, because it's something that we sometimes forget about. Whereas that our patients who are, even when our patients are vaccinated, it's really important to try to quarantine within the household to prevent spread, because we definitely have seen many cases where it's ping-ponged through a household, even one where there's vaccinated household members. So now I'm going to move to a slightly more complicated, or probably a much more complicated case, and that is case number 2. So you're going to have some questions to answer here, but let me tell you about the case first. So we have a 52-year-old male. He's not vaccinated. He has morbid obesity. He's on day 6 of illness. And he has profound fatigue, fever, and cough. He works as a bouncer at a bar. This was actually, I saw him very early on in the pandemic. But we're going to pretend we're seeing him today for the purposes of practicing the best approaches. He's tachycardic. He's afebrile. His respiratory rate's just a slightly high, and his O2 sats is still normal, 95%. But he appears fatigued, but no acute distress. So what do we do with him in current best practices? We're going to perform a PCR test. We're going to complete a healthcare proxy if he doesn't have that completed. But what else are we going to do? And here are your options. So, and dive in there so you can see how people are responding. But the big options here are: do you want to do diagnostic tests to figure out what to do next? Chest X-ray and blood work. Do you want to, if you want to do that, that's questions A and B. There's two different approaches, and you can see what those are. One involves a troponin D-dimer, and the other is different in A and B. So that's one option. You're not sure what to do, so we're going to get some x-rays and blood tests right now. Option number C, discharge home. Tell him that he might be more comfortable sleeping on his stomach, and see him tomorrow in clinic. Option D is check a rapid antigen test today in addition to the PCR that you're already doing, and if possible and positive, arrange for same-day monoclonal antibody treatment. And then the last is refer him right now to the ED for with thinking that it'll be admitted. So I'll just give you a moment to answer this. So right now, the two most popular choices are to D&E, to check a rapid antigen test. That's coming out as number one, and by about half of respondents. And then a third of respondents would like to transfer him to the ED for likely hospital admission. So let's take a closer look at this situation. So how to think about this? Again, the question is, what's the best location, home versus hospital? And will additional diagnostic studies help us make that determination? And if he is sent home, what are some of the treatment options that we've covered already in large part? And what is the best timing of follow-up? So first of all, let's talk about those blood tests and chest x-ray. So most of you didn't recommend doing a battery of testing. And I agree with you. And here's why. So there are several studies that have shown that there are abnormal blood work, and here I'm highlighting what the ones that are most consistently from study to study that we're finding are. Mostly this is very significant elevation, so twice normal, twice the upper level of normal, with the exception of the absolute lymphocyte count, which is low, and LDH, which can be anything that's high, doesn't need to be twice normal. So these have all been associated with severe disease. So that would suggest that maybe we should check them to see how severe this case of COVID is. In the case of our gentleman back in March, he did have this blood work done, and he only had one thing that would have counted associated with elevated risk, which is his elevated LDH. So does this help us? Well, the theory might be that it could both, if there was a lot of positive tests here, suggest that this is someone who's going to get very ill, and then we could refer them to the hospital. It could also suggest that if everything was normal, that we could send him home with maybe a televisit in the next few days. But unfortunately, while we know there's the association between these lab values and severity of disease, what we don't know is when those the natural history of this. We have no idea if those lab values change ahead of symptoms. And that's really what we're wondering here. We can clinically evaluate the patient, but will it add anything to our clinical assessment? And the fact is that there's no evidence that it would from the literature. And in our clinical practice, at our COVID clinic, we haven't seen these labs to be particularly useful. But when would they be useful? They would be useful because, of course, now, and even in the midst of a wave of COVID, we're going to see patients with COVID, but then we're going to see a lot of other illnesses. And we don't want to miss bacterial pneumonia. We don't want to miss a pulmonary embolism or myocarditis. So these are things that's very important to make sure that you would do what you would do pre-COVID, pre-pandemic, to evaluate for those conditions if you think there's a possibility that those are cause for the symptoms. Oftentimes the tempo and the timing of symptoms will be key clues to distinguish these different illnesses. So for example, with influenza, you would not have a viral syndrome and then wait 5 days until shortness of breath developed. In the rare case, with influenza, the more common problem is some shortness of breath initially, if you're going to have it on the early on, day 1 or 2. And if someone develops a very rare influenza viral pneumonia, that's going to be extremely rapid, and people are going to be deteriorating within 2 to 3 days after infection. That natural history is very different than with COVID, SARS-CoV-2 infection, and that's the case for all of these diagnoses. If you want to learn more, there's a video that I've recorded, and there's a link to it down below where you could watch us try to tackle this, how we distinguish this in COVID clinic. I wanted to also touch on the use of home oximetry. So there's been a lot of excitement about this now for probably the first time in our lifetimes. A home O2 monitor is seen as a staple, maybe more so than a home blood pressure cuff these days. And the question is, so how helpful is this data? Well, the truth is we really are, again, we have no high quality data where we've randomized patients with COVID to having home oximeters or not, such that we can really understand whether or not the totality of the situation, the totality of using home oximeters, the benefit outweighs harms. So could there be harms? Yes, there could be harms because of false reassurance. There's many people, 4% of white people, 11% of black people, whose oximetry will be falsely elevated. So that could create false reassurance, or a faulty oximeter, of course. And it also, as we all know from our clinical practice, we can have false low levels as well. So that could create unnecessary concern or ED visits if patients are regularly getting low measurements at home. So my take home with home oximeters is, while I'm not opposed to their use, it's very important to use it as a very small bit of information when you're talking to patients from home. So it's pretty much in the category of, if a patient has a blood pressure cuff at home and they're measuring their blood pressure, we want to hear about that. Let's say we're evaluating them in a telehealth visit. But it's not something that we're going to make all our decisions based on. And the oximeters is in the same category. Use it as some background information you're getting, but make sure you're focusing on the patient, their symptoms, their stage of illness, and how they're doing from day to day, especially in that window of 4 to 8 days of illness, when it's most critical and it's most likely, if they are going to deteriorate, that's when it's going to happen. So let's talk about oral corticosteroids. The question here is, should oral steroids like prednisone or dexamethasone be used in outpatient setting? So to take a look at whether or not this would be wise, we'll take a look at the landmark study, the recovery study published in the New England Journal. And here we'll take a look at who benefited from dexamethasone 6 milligrams once a day for 10 days. And in this study, it was all hospitalized patients. And it's looking, and this graph looks at mortality benefit. Patients that are to the left of the screen have fared better, are less likely to die. And those to the right fared worse. So what we can see here is that if a patient was started on dexamethasone when they were mechanically ventilated or receiving oxygen, they had a mortality benefit. But what we can also see from the recovery trial is that if patients, and these are hospitalized patients, did not require oxygen at the time that they received dexamethasone, they did not fare better. And the confidence interval overlapped with 1, so maybe it's neutral, but there was a hint that there could be some harm related to using dexamethasone too early. And that could make some sense, of course, as our patient's immune system is trying to build up a reaction to SARS-CoV-2. And if we're interfering with that by giving oral steroids too early, but then it's helpful during the very the later stages on days 4 through 10, when patients' immune systems are too revved up, overreacting to the virus, leading to the severe consequences. So now let's turn to a very exciting and very fluid area, which is the use of monoclonal antibodies for outpatient COVID. So the names are complicated and tongue twisters, but the good news is right now you don't have to memorize them, because what you need to know is that there's 3 different monoclonal antibodies. 2 are combinations and one's a single antibody that has emergency use authorization from the FDA to use in the States. You also should know that they're all intravenous, and that the data suggest in all cases that they can prevent both, in high-risk patients, they can prevent both, decrease the rate of, not prevent 100% of course, but decrease the rate of hospitalizations and death. So we're talking about very powerful options, therapeutic options. The problem has to do more with how to get this to patients, the logistics of use of these monoclonals. There was earlier some concern that the BAM-ET combination, the third one listed down there, was no longer effective against the variants that were circulating in the States. Currently, the CDC and the FDA thinks it's adequate. So right now, all 3 would be options. So, but here's what I want to emphasize. So what do you need to know about these? You need to know that they are all IV. There is a subcutaneous option but it has not been carefully studied. So the recommendation is to give these all IV. The next thing is about timing. It's probably extremely likely to give these as early as possible. And to emphasize that, let's take a look at what the inclusion criteria were in the major studies of these 3 that the FDA is permitting us to use. With CASI-INDEV, patients had to have symptoms for no longer than 7 days. For SOTRO, they had to have symptoms within 5 days. And with BAM-ET, they have to have received the monoclonal antibodies within 3 days of the diagnosis. So you can see that this is all very rapid. And the other part about it is that this is not given to all comers. In almost all of these studies, only high-risk patients were studied. So the risk factors are similar to the ones we talked about earlier, and this is from UptoDate. But other things can be included, and every hospital system will likely vary it. Here in our system, we use social determinants of health as a risk factor that's included as well. But the FDA has approved it for all of these indications. So everyone over 65, and then people with these comorbidities. And the FDA does not distinguish between vaccinated and unvaccinated patients. With that said, I would say that, let me just say what the authorization is. We're not FDA authorized for. It's not authorized for hospitalized patients due to COVID-19. They're probably too far along in their course. Any patient with COVID-19 that requires oxygen therapy, and anyone who has SARS-CoV-2 infection that was on oxygen, let's say for COPD, but now is on a higher level of oxygen from their baseline. All of those patients would not be appropriate to receive monoclonals, likely because they're too far along in their illness. So the FDA has permitted the use of monoclonals for up to 10 days after diagnosis. I think this is much too broad, as we're going to see most patients entering in that second stage where monoclonals are not going to be useful within 4 to 8 days. So I really would like to, ideally, I really would recommend getting it to patients within 7 days, and ideally within the first few days, if at all possible. And this is just a little more specifics, but most of it we've covered already. So let's return to our patient. And this was your top choice too, and it's my top choice as well, which is have a discussion with him about monoclonals. We haven't talked about side effects yet. There are some allergic reactions to monoclonals, but overall, people are reacting. The side effects have been minimal, other than rare cases of severe allergies, which have been managed, and none have been managed in the clinical setting where they're getting the infusion, and none have been, no one has died in the studies due to a side effect. So given the mortality benefit and the relatively minimal side effects we're seeing, I do recommend having a discussion with patients, and this patient meets the criteria because he's morbidly obese, and he's very borderline on days. I'm very worried that monoclonals are not going to be able to help him already. That's why I'm going for the same day monoclonals, because I think if we wait for a PCR test to return here and then we have a discussion about monoclonals, it's too late. It might meet the FDA's permission to use them, but I don't think it's going to help him. So I would go for rapid antigen testing. Now, just a quick reminder as before we wrap up that caring for COVID patients has had a huge impact on all of us in terms of mental health. So it's really important for us to be taking care of ourselves and be leaders in our clinic. When we were in the worst of it, we spent a lot of time making sure we shared not just the cases and working on our case conferences, but also shared our stories of what we were doing to rejuvenate ourselves, which often for some of us was spending time outdoors, doing home cooking and dancing. So some take-homes before we move to the take-home points before we move to the Q&A period. And feel free to write in your questions right now in the chat function. I can't see them, so you're not distracting me. And we'll get them to me in a few minutes. So the key is here, which we've emphasized a few times, is that the first few days of symptoms, it could be any viral illness. And it's really in the days 4 through 8, 4 through 10, where we really see this severe, serious COVID. But we want to try to treat, though, with the monoclonals during that first few days of illness. But in that second stage of illness, days 4 to 10, any worsening, those are the patients I want to see in person, because I'm afraid that they might be deteriorating. And depending on their symptoms, you could decide if that in-person visit and your setting, if that in-person visit should be in a clinic or in a hospital or emergency department. And this slide just basically covers that, including that it's a balance between what are the patient's risks. So you could have someone who's 20 years old with no comorbidities, who's quite sick, but they might be able to be managed by telehealth, but then you start having risk factors with moderate symptoms. I'd like to see them in person. Diagnostic testing is not recommended as a standard. You don't have to think there's a battery of tests, including a chest x-ray, that's necessary in patients who have straight ahead COVID. But if you're thinking about other diagnoses, definitely pursue that workup. One thing we haven't talked about yet, but is very important, is that in that second stage of illness, the days 4 through 10, a very useful test is having the patient in clinic walk around and checking their O2. So an ambulatory O2 sat we find to be super helpful, because oftentimes their oxygen saturation could be 95% at rest, but then could drop to 90 or even 80s with ambulation in the clinic. Home treatment points there's a lot of things to avoid, which we've talked about, but what you can do is stay well hydrated, isolate from the rest of the family whenever possible, and consider monoclonals for appropriate patients. Avoid antibiotics and oral corticosteroids. I just do want to say a caveat about the oral corticosteroids. If someone has SARS-CoV-2 infection, but you think that clinically their primary problem is asthma exacerbation, a COPD exacerbation, or something else that requires steroids, definitely treat with the steroids. Don't hold off on oral steroids because of your concern that it's going to worsen things. I've linked to a few other resources here. Feel free to email me directly if you have questions. And now I'll turn it over to you guys to ask me any additional questions.
Excellent. Thank you very much. Some specific questions actually on the cases. So back to the first case. Why was he not given monoclonal antibodies?
Yeah, so in the first case, let me see, can we get back to that slide or no?
Look at the back to you.
Yeah, we do. That's a great question. So the question is, why not do a rapid antigen testing here in case 1 and treat him with monoclonals? And I'll show you why. It's because he... Oh, I'm sorry. It's going to take me too long to scroll back.
Yeah.
So let me just say that he doesn't meet the requirements, the age cutoff. The FDA has age 65, I believe, equal to or greater than 65, or other comorbidities. He has no past medical history. He was from Brazil, so but according to the FDA's EUA, that wouldn't qualify him for a treatment. So that's the reason why right now they're not recommended for lower risk patients.
Okay. Now, a few people have been asking for the second case, what if his antigen test came back negative? Would you, I guess, sort of make a clinical diagnosis, send a PCR, wait? How would you approach that potentially?
Right. That's very important. So I'm glad that you asked that. The issue with that second test is extremely, because as we talked about earlier, the antigen test is not, its sensitivity is not great. So let's say it would only pick up 70%, and actually he's on day 6. So the chances that it's probably the sensitivity is greatly decreased for him, and it might just be 25% or so. So unfortunately, it's extremely important to wait for that PCR test to come back. Given my feeling that it's very hard these days to, or if impossible, to get an infusion of monoclonals without a proven SARS-CoV-2 infection. So unfortunately, it's going to then be totally dependent on your turnaround time for your PCR. If your turnaround time would be first thing in the next morning, or you call up the lab and say, hey, could you guys run this fast, then maybe he'd still be in the window for monoclonals. He would technically be in the window from the FDA's standard, but I wouldn't recommend it because I don't think it would have much benefit after 7 days.
There's a question about molnupiravir. Any thoughts on that drug?
Thank you so much. So, this is we're starting to a new era that we're just around the corner of, and actually, the new data came out after I prepared my slides, and it's still not ready for prime time, so that's why I haven't mentioned it yet. But I'm glad you did. This is an oral pill that's an antiviral. So the idea is you take it early, and it decreases replication of SARS-CoV-2. What do we know about it? We know that there's a preliminary study that's a preprint that's out there that has no clinical outcomes, but just looked at viral replication. So that's not very useful for us. And then we also know that the company that makes it has released a press release saying that they have a clinical study showing that it decreases hospitalizations. So that's basically where we are right now. This could be completely game-changing once after the FDA evaluates that data or it gets published in a peer-reviewed journal. Right now, no one has access to this information, so we certainly can't recommend it. And it's not even, just to be clear, it's not even FDA approved for any use. So it's not like we could pick this up because it's been being used for hepatitis C or something right now and start using it. It doesn't exist. So this is going to be this could be in the future, but hopefully, in the next few months, we could get some clarity, and maybe this will be another part of our armamentarium in addition to the monoclonals.
Great, thank you. Someone wanted advice on managing the headache that we can see with COVID-19. Right.
So the headache, so there's two problems with the headache. One is that as part of the acute illness, it's a common symptom. And for that, we would start with acetaminophen, Tylenol, but we'd be very comfortable if that wasn't adequate, moving to NSAIDs or even higher NSAIDs if necessary. It is of note there are some patients who have persistent headache for weeks and months after their initial COVID infection. Let me just say that's rare, but it does seem to be an entity that we're seeing. What my recommendation right now is, because we don't have any specific known treatment for that headache, my recommendation is to make sure the patient isn't suffering from rebound analgesic headaches. A very common problem that we're all probably familiar with after the acute illness. They've been taking acetaminophen, NSAIDs for 7 to 14 days, and now every time they try to stop, the headache comes back. So I would have them do a trial of 2 weeks, 3 weeks without any analgesics to rule out rebound analgesic headache before I start trying to figure out what I would do about a chronic headache that's occurred only after acute COVID infection.
Here's a question about using monoclonal antibodies and whether you would sort of approach that differently in patients who are vaccinated versus unvaccinated.
Yeah, so that's a good question. So I'll just say that the FDA says to treat everyone the same. And that certainly appeals to me from a moral standpoint, that we shouldn't be doing different treatments based on someone's decision about vaccination. From a practical standpoint, though, and this is one thing, now I'm not talking about the FDA recommendations, I'm talking about what I would do in my practice, what I do in practice. What I do in practice is assess the overall situation. So while these studies were done for mild to moderate symptoms, so everyone has to be symptomatic. We're not recommending, what I'm talking about today is symptomatic treatment of SARS-CoV-2 with monoclonals. I take an overall assessment of the situation, and who I would like to, I do a comprehensive evaluation of the patient and decide, is this someone who I think has a decent chance of ending up in the hospital or in the ED? So I'm taking in the traditional risk factors, I'm taking in their social determinants of health into account, and I'm taking into account their symptoms. Almost always patients who end up in the ED or hospitalized have more severe symptoms earlier on in their illness during those first few days. Not always, but most of the time. Therefore, I'm taking all this into a clinical assessment. And if I think that someone has a chance of landing in the hospital, and they're in that early window, early days of COVID, I'm going to strongly recommend monoclonals. If they are, and vaccination does come into my clinical play, because most of the patients who are vaccinated who I'm seeing with acute COVID are not as sick. Their symptoms are much less. So yes, that's how I incorporate it into my clinical reasoning.
Thank you. I'm sorry to do this, but for your last question, or for our last question, there's been a little chatter and some uncertainty about your conclusions regarding both colchicine and inhaled corticosteroids. So can you give us like a 30-second bullet on the bottom line for both of those agents?
Colchicine, not ready for prime time. One carefully done, interesting study has been published to suggest a potential benefit needs to be duplicated. In terms of corticosteroids, inhaled corticosteroids are definitely not ready for prime time. The two studies have conflicting data and do not suggest a decrease. The best data does not suggest a decrease in hospitalizations or mortality, so I do not recommend inhaled corticosteroids.
Great. Thank you so much. Excellent talk, some very nice feedback and good questions from our audience. Our next talk will be in 5 minutes.
Thanks for having me.